We are live now.
Yeah, so Namaskaram and welcome all. Today we have Dr. Parshava Mehta with us, who has done his Pharm.D from Sri Ramakrishna Institute of Paramedical Sciences in 2016. He is here to talk about and give an overview of pharmacometrics. So after his graduation from Pharm.D, he worked at Apollo Hospitals, Gandhinagar in stem cell transplant unit. So later, he bagged the Oncotherapeutics Fellowship at Tata Memorial Center. He is the first graduate of Pharm.D to achieve this. So during the fellowship, he developed a keen interest in pharmacometrics, following which he worked in Pumas AI for a year, where he built his roots into pharmacometrics. And currently is pursuing his PhD in pharmacometrics from University of Florida. He has deep interest in applying these models to the clinics and focusing on precision medicine. So, Dr. Parshav, nice to connect with you again. Welcome.
Hi, Karthik.
And thanks for taking your time and agreeing to talk to us. So, actually, I
It's my
invited
pleasure always.
him to address students at a conference we did at Hyderabad. And that time, I was pleasantly surprised to see his simplicity. In spite of achieving so many things, he was very simple, humble, available for interaction with students, and did a great job. So today we have an interaction with him.
Thank you.
So what we will do is I will start by asking you a few questions about the fellowship, and then we can go to the actual pharmacometrics topic.
Sure. Yeah.
So at what
Sounds good.
stage of Pharm.D did you get this idea or interest in doing the fellowship? When did this first thought come, and when did it become like strong?
I think the first thought came in somewhere when I was in the fifth or the sixth year. I don't remember exactly. But yeah. So I was just browsing the internet, and then I found this fellowship, which had been started by Tata Hospitals. So then I was always interested in oncology also. And so that time so from that time I built my mind that okay, I want to do something in the field of oncology, and I wanted to do this fellowship. And after I moved to Apollo Hospitals, where I was lucky enough to get a chance to work in the stem cell transplant unit, so I got a chance where I learned quite a bit of how the stem cell transplant therapy works, because it is a long process. It goes on for almost more than a month many times. And so so taking care of those patients and then addressing all their issues with medications, and they'll still have a lot of questions. So many are children also. So it was a good experience where I learned quite a lot of things. And I was even able to do the chemotherapy admixtures there. So I learned about the various doses that were given, because I was only actually mixing all of those. And then I had to be sure that you are doing the right thing, because even a slight mistake in those doses could lead to toxicity. So you have to be very careful. It was a very sterile environment where we used to mix all those. And so that way I learned from a lot of protocols and all that. And that's when that I was like, okay, this is the best chance for me to learn and then join the fellowship. And then I started seriously working towards that goal.
Yeah. And how did you start preparing? Now, let's say you got this idea in fifth or sixth year, it strengthened when you were working at Apollo.
Correct.
How did you start preparing for it?
So the first thing that came to my mind as to what, because not a lot of material was available and not a proper syllabus is available, that you have to study these few things and go and write the exam. So it was just more or less uh, diff, you have to know everything. So I tried to think in my mind that who were my other competitors. So my other competitors in the exam were all were all MDs, and they were all pharmacologists. So this was the criteria that I read on the advertisement. So I knew that if I have to compete with an MD pharmacologist, I have to think at their level. So I have to reach out, or to compete with them, I have to think from their perspective as to what kind of questions would an MD pharmacologist be asked. So I took an MD pharmacology syllabus, which is being taught in MD, and then I figured out a few books which they are taught. What are the lessons that they are being taught, and everything. And then I started learning all of that, and then I tried to match what is there in PharmD and what is there in the MD syllabus. So then, so that's how I actually started to prepare for the exam, because there was not much available. So this was the basic that I started with.
Okay, and how was your interview experience? Because I think the process involves written test followed by interview. So can you share your experience of attending that interview?
The interview experience was, trust me, one of the best that I have ever had so far. Still now, I've never had such a good interview. It was there were like four people in the interview, all senior people or senior doctors at Tata hospitals. One was obviously Dr. Gota, who's the head of the clinical pharmacology department where I worked with, and other is the and other was Dr. Naveen, and who is a stem cell transplant expert, and he's a specialist, and very few in India who does that work, and his work is really admirable, and his dedication to his patients is something that is at an other level, which is very difficult for which is very difficult for anybody to match. And the other one was Dr. Manjunath, who again works in the same department, and other was a statistician. So it was a panel of four people, and they would ask you definitely top level of questions. They are not just they are very well experienced people, who have been working as scientific officers at Tata hospitals. So their level of questions are you have to exactly think from an MD pharmacologist point of view, that you are an MD student, and they will ask you questions like that. So if you have to compete for the exam, you have to go with a mindset, or you have to be so well prepared that you should be able to answer questions what an MD pharmacology student will. You are no more competing as a PharmD, you are competing there as an MD student. So you have to be top notch in what you want to achieve there. Sorry, Karthik, I can't hear you. Or
Yeah,
you're
I was
muting.
on mute.
Sorry.
So, yeah, so I was really proud to see your profile on LinkedIn. I think that is how I connected with you.
Mm-hmm.
To come see that a PharmD graduate has competed with other MDs and qualified not just the written test, but got into this program. So it is not just an achievement for you, but it is an inspiration and proud moment for all other PharmD graduates. And
Yeah.
I also, what I like is when you prepared, you did not have any guidance, but I remember sharing your contact number and email ID with few students who wanted help with the exam and also the interview. So after you joined, can you quickly tell us what did you learn in the oncotherapeutics program?
So to quickly brief it out, we worked on a various we worked on various phase one clinical trials, which were happening in the department. So I was on the board of that as well. So I was working there as a senior resident, and then and so we were working on phase one clinical trials. A lot of investigator initiated trials were also happening there. So it was a full background and completely working on clinical research over there, and that's when I actually came to know that, okay, how a full-fledged clinical trial actually works. It is not just about so a clinical trial is not just about enrolling a patient, collecting the required data, but it starts from the very beginning, wherein you prepare a protocol, where you design your study, what is the research question that you want to answer with that study, and then you submit the protocol to the institutional review board. Then the board has a meeting, so you have to make sure that you submit the documents perfectly right on time, because or else the institutional review board is always flooded with a lot of projects and all that. So if you delay, obviously they're not going to take it in. And if you don't submit it right on time, then you're losing out real time on doing the study, because the institutional review board meets like once every month, or sometimes even 2 months. So depends on the place where you're working at. So the full process starts with that you submit it to the IRB. Then they could ask you for revisions to the protocol. They'll ask you a few questions. You reply to those. So only after the IRB is completely convinced that your protocol is actually going to make sense, and it is going to address the research question that you really want to ask, only then will they approve it. And only after approvals from the IRB, then you can start the studies. Without that, you cannot do anything. And then you enroll patients, then you collect your data, um, and then lastly comes, what do you do with all this data? And so now you have all the data. So now how do you work on this data to answer your specific question? So ultimately you publish so you analyze the data in whatever way it be, whether it's PK data, or it's any kind of PD data, or some other kind of data. It can be, there are different and lots of kind of different data that you want to address, and you want to learn from those.
So it was more of the clinical trial part which you learned during the fellowship.
Completely, yeah. It was a
Okay.
completely
And
full-fledged clinical trials that were run. That is, you can obviously learn, or you can obviously put your hands on to learning various assay technologies also, because the department has a fantastic assay team, bioanalytical team, I mean, which does different kind of tests, whether from around starting from ELISA. Then they do a lot of so then they have HPLCs. They have everything there. So you can actually, they have an excellent mass spec also there. And so you can learn whatever you want on. And they do a lot of preclinical work also. So if you want to put your hands on to learning some preclinical work also, you're always more than welcome.
okay. So now the fellowship part, I think we have good idea. So when did you develop interest in pharmacometrics? Because there are very, very, very few people in
Okay.
entire country, and specifically with family background. So when did you develop that interest, and what
I
happened
think I
later?
posted a question. I think Alvin has posted a question. Can you let me know what are the answers for that? A yes or a no?
Yeah.
How much
So actually
how
there
much
is a
percentage? How much
poll.
percentage or something?
All of you
I
participate in the
just
poll, and
Yeah, I just want to quickly know, how much or how many people know of pharmacometrics. What is pharmacometrics? I will start with the real basics also when I start, but I just want to know. Okay.
yeah, always when you
Yeah,
know the
so
results, you can tell.
yeah,
So
so
yes,
until
when
that
did you
comes up,
develop
Yeah, we
that
have
interest?
only two people voted for. They have heard about pharmacometrics.
oh, only two people? Okay.
Yeah.
And the rest, I believe, but we have 87 on the call, so it's just okay. That's nice. No problem. That's good. So I have the correct good number of people who don't know it. So that's good, because I'm going to start with the real basics, and it's going to be really, very simple of what is pharmacometrics. And yeah, so to answer to your question is, I started. So the place where I told you is when we have PK data. So what do you do with that PK data? You've collected concentrations, you have everything. So now what do you do with that data is the next thing, or what you can do. Can do is the most most important question that you would want to answer. So, and I was always interested in pharmacokinetics, but I didn't know that such things actually happen. But trust me, I didn't know about it, but pharmacometrics was being taught at the PSG college, where they had like a yearly program of uh, of of pharmacometrics metrics metrics, which was being taught. And that's where so I didn't know about it at that time, so probably whatever it was. So ultimately, when I went to Tata Hospitals, only I came to know that okay, there are certain softwares which actually do this work, and you can do a lots and lot of things with pharmacometrics. People have started using pharmacometrics even for doing pharmacoeconomic studies also. So it is not just limited to just PK modeling, but the people do PK work, PD work. They do both combined PK PD. Then there's something called as PBPK, and it is just too vast. It's just too vast and it's too big.
Can you talk a little about how you got this PhD in University of Florida, which is one of the prestigious institutes? And then we can go with the
Yeah.
presentation. Yeah.
Sure. Yeah, so what is that is so initially I didn't know about pharmacometrics. So I started learning the real basics of pharmacometrics metrics when I was at Tata Hospitals, because they used to do quite a lot of work in PKPD modeling. And so I started from the real basics and the real scratch, and then we had a certain and then we had like so my mentor was very keen that if you want to learn pharmacometrics, you have to teach students about pharmacokinetics. So I used to take regular classes, apart from doing all the clinical work and the research work. I used to take classes there on pharmacokinetics over there for the other graduates, for the other students who were in the department, and everybody used to attend it. So I started with that, and then slowly I moved onto since I was teaching. So only when you teach, you get to learn your concepts, much better. And I always love teaching students because it's just real fun. And that way, at least you keep on learning again and again and again, and that's when it just becomes like really thorough for you. And not like I know everything, but every time when I teach something, I always learn, because there are different kind of questions that are being answered, that are being asked by students. And so you tend to answer to those questions. Sometimes you don't know, or many times you don't know, so you have to refer back, learn, and then you answer to them. So that way you tend on learning really a lot. And then post that I was working with Puma's AI. So working with the team at Puma's AI was like a really very good experience, wherein I learned a lot of the concepts like really properly. And Dr. Vijay and Dr. Joga, Dr. Surlivel Rajan, all of them, they used to teach us the concepts. We used to learn those, and we had like a small boot camp also, so that was conducted during the lockdown time, and a lot of students from India attended. I think I believe there were around 25 to 30 students who were there. We all worked remotely, and that's how it slowly kicked in. And then I applied. So once getting some knowledge on pharmacometrics, then I applied to the University of Florida, and my mentor, who I currently work with, Dr. Valvanera. So then she was interested in my profile, and then on, yeah. So that's how I got through the university, and yeah. So I'm currently here.
Yeah, so happy to know that you love teaching and sharing your knowledge with students. So after this
Definitely.
session, actually all the participants, maybe Alvin, you can take one more poll and see if they want to know more about pharmacometrics. In next half an hour, you will get an idea on what it is. And if you think that interests you, we can always get back to him and see if we can do a series of sessions where you get little more than the introduction part. So Parsha, finally, it is over to you. You can start sharing your screen and present.
Yeah. Thank you
And
so
I
much.
might leave in between. At the
Okay.
end, if students have questions, you can feel free to ask.
Oh,
And
sure, sure.
like, I'll make sure we stay in touch with all of you in case you want to know more details and go in depth of this pharmacometrics.
Sure.
Yeah, yeah. Okay.
So can you guys see my screen?
Yes.
Yes, sir.
Okay, cool. So I believe not a lot of students know about pharmacometrics. I was also like one of you guys. So I'm gonna go into the very basics of pharmacometrics, very basics, but with a few applications, one or two applications of what can be done, and following with I will just give you a few of the softwares. There are so many softwares which are used to do pharmacometrics, and I will just link you to a few places or a few resources where you can put your hands on and slowly start learning if you're really interested. And I hope this presentation interests you to the world of pharmacometrics. So in between, if any of you have questions, please feel free to stop me at any point of time, and I'll be more than happy to answer questions. And I hope you all understand. Okay. So my road to pharmacometrics, like I said, always started with the Tata hospitals where I was working at, and this is where I came to know about metrics, and then I started working on it over here. Okay, so now I have these two pictures over here, and I'm going to break down pharmacometrics into two things. Meaning, like, I have a photo, or like two photos. One is a house, and the other one is an aeroplane. Something, probably maybe the Wright brothers developed one like this. So yeah. And so what are these actually? What are these pictures, or what do these pictures represent? If I have someone who can just, I like it to be more interactive rather than me, talking continuously, because it's just really basic. But yeah, if we can have someone who can at least talk something about it, or what do you think? What are these pictures? Are these real houses, or is this like a real airplane, or something?
Simulation.
Okay. So these are actually basically models. Simulation is what you actually do after that. But before that, you build something called as a model, and that's what and modeling has been done from a very long time. Even when you say you want to build a house, you go to an architect, and architect develops a 3D model for you. He shows you that, okay, this is how your house is going to look like, and he shows you that. So prior, even before you actually start constructing your house, you have some kind of idea as to how it is going to look like. And this has been done from ages, whether it be on building house, or whether the people used it to build an airplane also. They developed some kind of model, and only after that they actually built the model, built the airplane or the house. So that's how. So this is the real basic and the fundamental of the whole pharmacokinetic, where you build a model, you simulate with that model, you predict something, and when you predict something, with the help of that, you answer certain kind of questions or your research questions, what you actually want to answer. So this is the slide uh, which I am more interested in, because obviously I don't develop house models, or I don't develop. I work with human patients, and this is actually the model that I like. I don't know why he's keeping a hand on it. Please don't ask me that question, because I don't know why he's keeping his hand like that. But yes, this is a model of a human being, and you can see that some kind of drug is being dosed into the body. So this is the real basic or a very fundamental of the pharmacometric models, because we deal only with patients, and this is a human subject. So when we're dealing with this human subject, and since I'm not very good at drawing or anything, so I just put a very simple box around to just replicate the human, because my drawing is very, very bad, and which I'm very sorry about. So I just put a simple rectangular box which represents the human body, and I give some kind of a dose to the subject, and this human being has some blood, whether you say blood or let's call it fluids. They have the fluids which are represented inside, which have some volume. And as a, anything that goes into the body, and which does it work and gets back, it has to ultimately be excreted from the body. So it is just cleared out from the body. So this is a very simple, or a simple representation of a human being. This is my model, which is a human being who is being dosed an IV drug. I don't know what drug. It has some volume of distribution, and it is being ultimately cleared out. So this is how I represent my model. You can write this in terms of, I'll not go so much in detail about writing it as a differential equation and all that, but this is just very simple representation of this figure that this is how I like to represent the one compartment model that I work with. Okay, so now you have a model, but why do you write a model? Can anybody tell me why do you write a model, and what do you do with it? Nobody? It's okay. That's fine. I know it's difficult. So why do you write a model, and ultimately what do you do with writing a model? The the use of you writing a model will be to predict something. You are going to actually predict how the concentrations are going to be within the body, because so initially you don't know how it is going to be, and so you write a model and you say that, okay, this is how I think the drug is going to be in the body. And so from this graph, you can see that the concentration has started at 100, and it went on. So the drug is almost cleared at around 12 hours. So then somebody will ask, okay, so what do you do with this? Have you And how did you predict it? Have you collected like samples around everywhere? So the best part about predicting something is that we are not collecting samples. You are writing something, and you are just predicting, and this is what a software does for you. It gives you the complete profile at every time point that you have requested it to calculate. So it's just maths, and they just do these calculations over and over again, and they'll come out with final definite profile of the whole thing. So what happens in this is, in reality, you will never be able to collect so many time points. It is impossible. Well, your IRB will never approve of you collecting so many samples at all, and you cannot get such a great profile of a drug. So that's why you make a model and you say that, okay, this is how I think it's going to predict, or this is how I think it's going to work in the body. And you can say that, okay, in 12 hours, the drug is going to be cleared out from the body completely. So from just seeing this graph, you have made certain kind. Uh, Sorry. Okay. So yeah. So this is how you make your interpretations from just seeing a graph and seeing a model that was written. So I'll now slowly switch gears to something called as, what is variability? Can anybody explain what is variability in real world, or in very basic simple terms, what is variability? It's a very funny story that I'm going to explain to you from my part of what is variability. Okay, so let's move on, and let me tell you this very interesting story. So you can see a very nice, handsome model, and he's got a nice haircut. So I went to the barber yesterday, and I told them, okay, and I showed him this picture, and I told him that, can you get my hair cut this way? So this was my model, which I showed to him, and you can see what he has done. So ultimately, he did not cut it the way that was shown in this, and he cut it to something what you can see on my head now. So these are completely different. So it is very important to understand that even if you have a model, doesn't mean that the actual output is going to be the same. It's going to be different. It's going to be variable. It's not going to be the same. So this is what I want to emphasize on the fact that what you predict from your model may not be the same as the actual outcomes in real life, or in real or from the real data that you collect. So then your next question would technically be is, if it is variable, what is the point in developing a model and writing so much, and then you predict something to ultimately not get your same results? Okay, so what is the thing is that even though it is variable, we know a prior that you have to account for such kind of variability in the model, and we know that that there are certain parameters in the model, like the volume of distribution in this case, and the clearance in this case, because it is a very simple one compartment model which has two sets of parameters, like your volume and your clearance. So these are the only two things that are going to be different for me in my model. So knowing that prior that there is going to be variability, within the population, I tried to write this a prior in the model, and then with my data, I tried to estimate the estimate that each patient is going to be variable. They're not going to have the same clearance and volume of distribution at all. Each and every patient is probably going to have a different clearance and a different volume of distribution. So you write this prior in your model, and you tell the system to actually calculate what is going to be the variability, whether it is 10% variable or whether it is 20% or 30%. Meaning it will have a central value followed with 10 or 20% changes in the actual value. Okay, so that's what I did. So now I've got 4 patients who have different values. One has a lower clearance, the first one you see. The next one you see has a bit of higher clearance than the first one, then more high clearance and more high clearance. So you can see technically that that this is how the profiles are going to be for each and every patient. And this is also something that I have predicted with my model, because I written in my model prior itself that each patient is going to be different, and each patient is going to have a different set of clearance and a different set of volume of distribution, because each patient is not going to be the same. So I wrote it prior itself, and I told them to calculate the concentrations, how they are going to look for these 4 patients. And these were the results from my model. So now, just to sum it up again, or just a quick revision, that we know that we have a model which has a certain set of parameters, like in this case, they are the clearance and the volume of distribution. So these are the parameters that I have given in the model prior, following which I told my model that each patient will have a different set of clearance and a different set of volumes of distribution. I told them these are the 4 patients and they have different sets of values. So take these values and then you calculate for me and then you tell me. So that is the first level of variability that is present in the thing. Next is the, or you say, the intra-individual variability or the individual patient variability. So next is this variability. So now we measured concentrations. I predicted something with my model, and now someone gives me the data. So I got the data, and I now overlay the data with my prediction, and still this is for just a single patient. I collected 6 samples over a period of 12 hours, which is again very difficult, but still I collected all of them, and I predicted something, and these are the concentrations that I got from the patients. These are the concentrations that were measured after collecting samples, and the analytical team has done a job where they found me the concentrations and they gave me. So now somebody will ask you, your predictions are not very good. There are a few points which are going above and few points that are going below, and just 2 points that you predict perfectly. So they'll say, so this model is not good. So do you think the model is not good, or do you think is there something else on it? So what is the case is that whenever you run an assay, uh, there will be some kind of variability, whether it can be the assay variability or whether there can be so many other factors that are responsible for this difference in concentrations. Sometimes it's very possible that when you ask someone to collect the sample, instead of collecting at say 10 hours, they could have collected it at 10.2 hours, and they might have reported it as and it was just mistakenly, and that was not acknowledged. It was still mentioned that sample was collected at 10 hours. They did not tell you that it was collected at 10.2 hours. So your model doesn't know that it was not collected at 10 hours. It was collected at only 10.2 hours. That is something that the model doesn't know. So your model only predicts the values at 10 hours. But your observation is at 10.2 hours. That is one factor of variability. The other is when you run an assay, like I told you, when you run an assay on the same sample, you will not get the same concentrations each and every time. So you have to account for this second variability that is there in the patient, that is there at the individual level, that is at the observations level. There was another previous one that was another variability that was at the parameter level, that was for your clearance, and your volume of distribution was completely different for all the 4 patients. But here the variability this is the second level of variability that is there at the observation level. Each observation is still going up and down. So you have something called as your residual variability, where you calculate a value or a difference between what you have predicted and what has been observed. So this is also something that we account for in the model, and we prior itself tell them that it's going to be so much. Now the system will try and estimate how much is that variability or that level of error what is there in the subject. So one more switch in gear is, now how many of you like maths? Let's be honest, let's have a small chat. How many of you like maths? How many of you don't like maths? I'm going to see the chats. You can see them as well. Just a quick yes, no, like maths, don't like maths. No, yes. Yes, no. Okay, very good, perfect. Hate maths. Even I hate maths. Okay. I didn't know maths at all, and I didn't take engineering for the fact that I knew I would fail in maths in all the 4 years of, because engineering is all maths, and whether it be in physics or whether it be in the actual math subjects or whatever, I don't know so much, but I knew that I would fail in maths and I would not do great at maths. So I didn't take engineering, and I went on to take founding. And but there is this one simple equation that all of us have learned, that is linear regression, and that is y is equal to mx plus c. This is something many of us remember, and I'm sure all of us, even if we hate maths, we still know that okay, there was some kind of equation wherein we studied y is equal to mx plus c, because this is there starting from I think 6th or 7th grade, and we've been learning this equation for many years now. Even though I don't like maths, but now I've started to like maths because it's just getting interesting, and we use quite a lot of math in doing all these calculations. But the fun fact is, you will start liking maths because math is it, I wouldn't say the basis of everything, but still math is a big component that plays a big role. But still, ultimately, the software does quite a lot of stuff for you, but you should learn to interpret all those values. And because you have the knowledge of how the body works and what are the biological aspects of quite a lot of things, this math is very interesting, because you are technically reducing, or you are just doing math on your body, and you're ultimately coming up with numbers which you're ultimately going to interpret, and how you're going to interpret is up to you, up to the person. So we all know of linear regression. So can you tell me, can we fit a linear regression model to this graph, to this concentrations what I predicted? Can we fit this linear model to that? Quick yes no's in the chats. Right or wrong is not the thing. Nobody knows what is right. Even I don't know. Yes, good. Okay, so we have a few answers now. Linear regression. So what is linear regression? It is a kind of a thing. It's a kind of equation where it keeps on. It could be it could have either a positive slope, or it could have a negative value, wherein the concentrations are coming down. And you can do this kind of linear regression on basically any two things. It doesn't have to be concentration versus time always. But the fun fact is that your concentrations, which you see here, are not, you cannot fit a linear regression model on this one, because you have to fit something called as a non-linear regression. So that's why we use something called as a non-linear mixed effect model. That is, non-linear is the thing, because you cannot fit a linear regression onto a thing. It will not, it doesn't work that way. And maybe details all for a later day. But yeah, so we do something called as NLME, that is non-linear mixed effect modeling. And so you fit a non-linear regression, and then you fit this equation. This is a simple one compartmental equation, which a lot of us know. We have been learning this. And how this is written, I did not write this equation. I just copy pasted it from somewhere. The system gave me this equation, but I wrote only the differential equation into the system with the help of the initial model that I showed you. That was my one compartment model, which was something like a box with an arrow, something going outside, and I just wrote that equation. And the system integrated that over time, and then it came out with this equation, and then it calculated it for all the 4 subjects. So these were the observed which I got from the 4 subjects for each of the thing, where I gave the level of variability at the parameter level, that is for clearance and for the volume of distribution. I gave it. In this case, it's Ke. That is again CL by V. So you can use that. So you can even do it that way. But mostly it is characterized in terms of CL and V. Not going so much into detail, but again, yes, that's the thing. So at each level, my system was able to calculate. I just gave these observed data. I did not give this predicted thing, but I wrote a model which told which had a differential equation, which had some level of variability that was prior informed to the thing, that the clearance is going to be 10% different and the volume of distribution is going to be 20% different. And I even told, so that was the first level of variability, and I even told the model that there is going to be variability in the observations also, because 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 someone who collected the sample has done some mistake, and even the assay that has been reported, there is some problem in that. So I'm writing that there is going to be so much error, which is around 20%. So you kind of please calculate what that error is going to be. And they calculated that error, and this is the final outputs that they got. So now, very good. Okay, I fit the data, I do everything. I predict that these are the concentrations, what are going to be the body, this is the clearance, blah 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 blah, everything. So now, what do you finally do with after getting all these values and with a model? So then I was just sitting by, and the doctor came and told me that, okay, now you have done a very good model, and everything. Now, can you tell me, for a patient who is having some kind of a liver disease, what is the dose that I need to give to the patient? So this is the research question that I wanted to answer. So the doctor asked me, what is the dose that you think should be given for an hepatic impact patient, but I still want to have that same level of efficacy, and still I don't want to reach toxic levels. So how do I do my kind of dosage adjustment for hepatically impaired patients? So then I began to think, okay, so now what can I do with this that I have? And there are a few patients from the concentrations that I've collected. They are having some kind of hepatic impairment. Maybe say your ALT is high, AST is high, they're greater than 5 times, or say 2.5 to 3 times higher than the upper limits of normal. What upper limits of normal? What is the reference ranges? And so you have patients in your data set, or you've collected concentrations for those patients, and what is that? Is that you have to answer this question. So I began to decide how I am going to do this. So I thought, let's take a patient, let's take these graphs, and now let me observe how they are different. So you can see, for the ones which are on top, these are all the hepatic impaired patients, and these are the other the patients who are not hepatically impaired, and these are they have some form of hepatic impairment. And so you can so from this graph I was able to clearly see that, okay, these are the subjects who are having a clearance that is lesser than these subjects, because at 12 hours for all these subjects the clearance is meaning the drug is almost cleared off from the body, but in these subjects the drug is still there. So if you technically give the next dose over here for these subjects, it is going to rise, it is going to have this much of accumulation, and then it's going to rise. But for these patients, they won't have much of accumulation. They're again going to start roughly at again 100, and again they're going to drop at 12. And these are going to start at around 120 or 140. So the accumulation factor in these patients is quite high. So to account for this, I added hepatic impairment as one more concept, as a covariate, or what it is called. It's called a covariate, and you add it to clearance, and I calculate the clearance what is going to be for these patients. So once I have the clearance that is there for these hepatically impaired patients, I will then be able to help the doctor with the research question that what is the next dose that is required for these set of patients. So this is one of the applications of using a pharmacometrics model, and this is how it comes on your label, where they clearly tell you that if you have a moderate impairment, the dosage adjustment is around 50%. Reduce the dose to 50%. So this is how it is being calculated, that okay, this is going to be it, and this is how you reduce the dose. Next, slowly switching to something more complex. This is called as a physiologically based pharmacokinetic model, which is much more complex than your simple. This is the next level of complexity, and still there is even more complexity that is added on this. But yes, this is one more level of it. Don't worry, these diagrams, once you know how to write those differential equations, you just have to write the differential equations, and the rest all the system does it for you. But yes, this is how you simplify your whole body into various compartments, and how the drug will move in all these compartments is what is your physiologically based pharmacokinetic modeling. And this, with the help of this pharmacokinetic modeling, you can actually find, or you can do a simple study, and you can tell that okay, there is a drug-drug interaction with rifampin, which is an inducer, as we all know. It is going to reduce the concentrations of my drug, and with this, you can do all this. So you have to they still did. So this was a paper that was published for a drug called ixazimib, and they used this, which is so this is from Takeda Pharmaceuticals, and they have done this study with the help. So though they initially did this study for hepatic impairment, to check for drug-drug interactions, and then they used PBPK modeling to actually come out with the research question that they wanted to answer. So you can read this paper, but yes, this is the whole crux of the thing. And yeah, so I am going to just end the session with a few softwares. These are not the complete list of softwares, but yes, a few of them are non-mem, which you can use, which is the gold standard. But still, there are so many other softwares like Monolix, there is Pumas, there's Phoenix, and all these are all, a few of them are you can use them, like Pumas is free for academia. Monolix is again free for academia. You have to write to them, and then they will give you access, and you can start coding. You can start learning, and there is another group called as Metro Institute where they have a lot of open science work, and they have a few courses which you can take, which are again free of cost. You don't have to spend money, so you can learn a lot of basics from all these things. And yeah, so you can learn all this, and I'd like to acknowledge Dr. Kotha, Dr. Kabru, Dr. Vaturi, Dr. Rajan, the team at Pumas AI, then Dr. TK Ravi and Sri Ramesh. And so this is all where I started Pharmacometrics. And lastly, I'd like to acknowledge Dr. Valvanera. This is where I currently work at the University of Florida. So that was just a very simple and a basic overview of pharmacometrics in general and what can be done with the help of pharmacometrics. I think I'm almost close to the end of the session, and if you have any questions, we can do them. I don't know how they want to do it. Do they want to do it right now, or you can ask me anytime. Depends on the time. Up to you guys.
Good evening, sir.
Yeah. Good evening.
Sir, this is Sai Sri. Uh,
Hi.
Sir, I have a small doubt. You have mentioned about you have mentioned an example of hepatic impairment, sir.
Mm.
So I would like to know how you decide whether to decrease the dose or decrease the frequency in such cases, sir.
So like you would get a certain kind of clearance out of it, right? So when you have the clearance, with that you can calculate uh, you can calculate the standard AUC of the drug, or the with the help of those predictions you can calculate the AUC, and with the help of the formula, clearance is equal to dose by AUC, and then so you can flip-flop it, and then you can calculate the dose that is required for a patient who has a certain set of clearance, because the clearance is going to be high for that patient, and so you would require a lesser dose. Say if the standard dose was around 500 mg, and then you went on to calculate it, and it turned out to be only 300 mg that you would want to dose for a patient with hepatic impairment. So that's how you decide, okay, with proper calculations you decide that, okay, that I have to reduce my dose by some percentage. If say suppose if the dose came out to be 250, then it would be like a 50% reduction in the dose.
Thank you, sir.
Yeah, thanks a lot. Hope that answers your question. Anybody else has any questions? I know it was a little bit, probably a little too much from a pharmacometrics point of view. It's still there's still lots and lots, there's a lot of complexity that keeps getting added onto every step of modeling and what you do, but this was the least that I could bring to your thing, that okay, this is like, I try to really put it down to just basic and simple and simplicity of the whole thing. But yes, it's not something to frighten you, but yes, it's definitely fun, it's definitely interesting. And
Good evening, sir.
good
My
evening.
name is Satyasri. Sir, I would like to know that is it necessary to put some focus over some softwares so that it would help us in designing all these models?
Uh, like I told you, there are so many softwares which have lot of differences around, but there a lot of use different kind of algorithms to find the ultimate answer. But if and I can even tell you that you don't have to really write all these differential equations or anything. There are a few softwares which are like point and click based. They have a lot of options. Those are all GUI based. You can just click what you want. You can say the drug is given as an extravascular, and you can say what kind of compartment model you want to fit on it, whether you want to fit a one compartment, two compartment, and you can just give in everything simply on it, and you can just click, you can just put your data inside. You can just do all these minor changes to so according to the needs of your data, and then you can just hit run, and the software will do it. But the main and the basic question uh, is that you really need to understand what the software is doing, and because you just don't want to run and come out with numbers and not it's not really helpful. It's always best that you understand the basics. If you're able to write all these differential equations, write it yourself, and if you're able to do all that with the hard softwares which actually require you to code, that way you tend to learn so much more than what you would do with just point and click makes your life so easy. But yes, it's definitely there. You don't have to code at all. You don't have to really require all this coding, nor do you require the math. Like I told you, you don't really require the math to really do all this. The software does it all for you. You just have to click OK and do OK. But it's very important that you understand the real crux or the real basics of it.
Thank you, sir.
Most welcome. Okay, I think we have a few questions in the chat box. There is one question which says, how does pharmacokinetics and pharmacometrics differ in terms of applying methods? Pharmacometrics essentially uses pharmacokinetics. Pharmacometrics is just quantitatively using pharmacokinetics. It's ultimately pharmacokinetics only that goes into pharmacometrics, but it's not just pharmacokinetics. It does pharmacodynamics also. Most of the times you just don't require just PK to do everything. You still require PK and PD to come up with answers, but everything ultimately depends on the research question that you want to answer. Pharmacometrics is more of using combining the knowledge of math and the knowledge of pharmacokinetics, combining your statistics with a little bit of biological systems, how you understand them, and then giving out the real answers. But they're not different. It's like you incorporate pharmacokinetics into pharmacometrics, and it's more of quantitatively. It's like more of quantitative pharmacokinetics. Oh, the next question is it mandatory to do fellowship course and then apply for PhD, or else Pharm.D graduate can apply based on his expertise in particular disciplines? So it is. I'm not saying that it's always necessary to do the fellowship and then apply for a PhD in pharmacometrics. I know people who have done it even without doing the fellowship, and they're doing really well. There are quite a lot of people who are doing pharmacometrics, but again, yeah, it's not really necessary. But you should definitely know. You should get your hands on with pharmacometrics to apply for a PhD program. Then it's much more easier, and it's easier to get through. Can you tell us how to apply and how to choose the right university, and what are the prerequisites to apply for any abroad university? I won't say there are like any specific prerequisites or anything. There were just specific prerequisites those are mandatory from the university. Your GRE and your TOEFL, many times GRE is waived off currently at a lot of universities. Only TOEFL is the requirement. But again, what they would ultimately look at is your CV, and then what I had to do is I had to give like a presentation of some of my pharmacometrics work that I have done, and so with the help of that, then they were able to actually, then it was when they decided that okay, he'd be a good candidate for our institute, and that's when they decided to take me inside. So and about the universities, there are quite a lot of universities which do this work, and all of them are equally good. So there are a few universities like University of Maryland, University of Buffalo does some work on this, University of Iowa, then University of North Tennessee, then University of South California. So a lot of universities do all this work, and all of them are all good. So you can just search for them and then apply to the professors. You can then apply to the professors, and then if the professors have and if they're willing to take you in, then they do it. So you have to apply. That's how it happens. The next question is, can I know about the Oncotherapeutics Fellow and Tata Memorial Research Institute and also the syllabus needed to cover up to attend the exam? Oh, like I told you, there was no proper syllabus, at the time, but you have to think from a perspective of an MD pharmacologist. So you can take the MD pharmacologist, you can take an MD pharmacology syllabus, and you can say that okay, they're studying so much, and then you can find the difference, and then you can find your difference that what are the areas that you don't really know. But they definitely do ask questions on pharmacology, pharmacokinetics, then a few on statistics, and then on clinical research as well. So these are maybe probably some of the few areas that you might want to consider. But still, yes, please do take a look at an MD pharmacology syllabus and then compare what you don't know and try to learn those aspects as well. So that way you'd be able to do much better in the exam. Is it necessary to remember all the pharmacokinetic data of all the drugs, or can we go with apps? It's really not required that you know all the pharmacokinetic data and all that. It is very difficult to know all that, but all these softwares have the inbuilt stuff of where you can, or you can even take it from literature if you want to. I don't know if this specific question is for pharmacometrics work. If it is for pharmacometrics work, then you can definitely take it from literature, and and uh, and it's so much easier. You can just take it from there. So you don't really require to know all the clearance and volumes of distribution of all the drugs. It is not possible also. But from a clinical point of view, for a certain drugs, you don't require to know the numbers, but you still require to know how they act, whether the action is delayed, or how things work and how it is absorbed, and a few things. For a few drugs, it is really different. Few drugs are all the same. It's not very different. So yes, but you don't really need to know all of them. Can you share some specifics about the preparation, including materials and books? Materials and books, like I told you, take the MD pharmacology syllabus. I think they refer to Katzung. Katzung is a very good book, so you can take Katzung, learn a lot of the pharmacology that is there in it, and that'd be really helpful. And other things, like I told, they do focus on pharmacokinetics. You can take Leon Shargil. That's a very good book for pharmacokinetics. Then statistics, you can get a lot of it from online. Clinical research also definitely from online. So hope I've answered your questions on it. And I think we have a last question. Can you please tell some institutes in India that provide PhD program after PharmD? Um, did I'd say there's so many institutions are there which provide a PhD program. There are so many institutes which do that, but depends on what kind of PhD program that you want to really join to. That will help you narrow down your search. Because if you want to join pharmacometrics only, then there is Manipal Institute. They do some really fantastic work. Then Tata Hospitals also Actrac also you can join. Jipmer does some work. PGIMR Chandigarh does some work on it. This is what I know, but yeah, there are, so these are a few institutes that do in pharmacometrics. JSS does in pharmacometrics, and so that's about it. But depends on what is your interest in the PhD, and then you can scale down and search to what you're actually looking for in your PhD program. I think I've answered all the questions.